Good afternoon and welcome everyone to our online information and support session. My name is Kathleen Helgeson and I'm the coordinator of the Patient and Family Resource Center. Surgery is the oldest form of cancer treatment and many people with cancer will have some type of surgery during their cancer journey. This afternoon, I'm joined by Dr. Megan Delisle, surgical oncologist at CancerCare Manitoba, who will be answering your questions about surgery and in general what you might expect. We're very pleased to offer this webinar with the generous funding support of the CancerCare Manitoba Foundation. I'd also like to take this opportunity to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe Cree, and Dene people, as well as the homeland of the Red River Métis. It's important for us to foster inclusion and reconciliation and encourage others to do the same. Before we continue, there are some basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your video are turned off. If you think of a question for Dr. Delisle at any time during the discussion, just type your question into the Q&A and she will answer, and you can also ask that question anonymously by checking the Send Anonymously box before you click on the blue arrow to send. My coworker, Allie, is also here, and she will be helping manage your questions as they come in. And if you have a technical concern, you can also ask Allie in the Q&A, and she will answer your question privately and try to assist you. It's my pleasure to now introduce Dr. Megan Delisle. Dr. Delisle is a surgical oncologist at CancerCare Manitoba. She specializes in colorectal cancer, melanoma, and breast cancer. She is also a scientist at the Paul Albrechtsen Research Center at CancerCare. Welcome, Dr. Delisle.
Thank you so much for having me. I'm very excited to be here and speak with everyone.
Yeah, thank you for joining us. And what I'd like to do, and we've talked about this when we talked about preparing for this, is to just check in with the audience, the people that are joining us today, to get a sense of where they might be at on their cancer journey, whether surgery has been a part of that. So what I'm going to do is I'm going to launch a poll, and you should be receiving that on your screen. And if it doesn't pop up on your screen, that just may be that your computer doesn't support it or your phone's not supporting it. But we just like to check in with people joining us and get a sense of where you're at. You can answer more than one question or more than one statement here. So either you're a person who's awaiting surgery, who's had surgery, that might be seeking more information about surgery, or perhaps a caregiver and or support person, or maybe you're a healthcare provider. So if you could give us that feedback, that would be wonderful. And maybe while we're just waiting for people to respond to that poll, Dr. Delisle, I'd like to ask you a little bit about yourself and what drew you to become a surgeon in the first place.
Yeah, so I love that question because it makes me think back to when things all started. And I think the two things I really liked about surgery and what made me fall in love with surgery was the immediacy of being able to help people, and also the vulnerability that people undergoing surgery are placed under. So, oftentimes that means you're asleep, and really you have to trust your surgeon that they're doing the best thing for you. And I think that level of trust and that relationship that you have with your surgical patients is very unique. And then with cancer surgery, I decided to specialize in cancer surgery. And the reason for that is because I think that the cancer patients are the people that are diagnosed with cancer and that live beyond cancer, have loved ones diagnosed with cancer. That entire experience is really life-changing for many people. And I think they become some of the bravest people, and they have a lot of insights into life and what it means to be like everything, like our day-to-day life and what matters, what doesn't matter. And I think being able to spend time with those people every day is really meaningful to me.
I agree. It's very true. And we get to witness those acts of courage and bravery every day, and the devotion of people like yourself that are caring for them, which is really nice. I'm going to end the poll right now and just share the results with everybody. So Dr. Delisle, if you wanted to comment, that's gives you a little sample of who our audience is right now.
Oh, nice. Yes, a person who's waiting for surgery, that can be the hardest time. Person who has had surgery.
Yes, we have
seeking,
a good number of people that have
yeah,
already had some surgery. Yeah.
yeah. So I'm sure that you probably have a lot to say about, yeah, your experience. So
Yeah. Well, let's continue on and just talk about the role of surgery. So we have some people that are awaiting surgery, maybe just not even sure if it's going to be part of their treatment plan, people that have already had surgery. When does surgery typically take place when somebody's been diagnosed with cancer?
yeah, so I think so surgery is can play a lot of different roles in the cancer journey. And I think when we classically think about surgery, think, oh, it's one of the things that we use to treat surgery. And that's for sure the foundation of surgical care in cancer is to use it as a primary treatment. But the reality is many of our systemic treatments have become so good now that we often also include, and people are living much longer, and so we often also use surgery to improve quality of life, and we do that more and more frequently. And so I think a surgeon and a cancer surgeon really stays on that cancer journey with the patient, with the people diagnosed with cancer throughout the entire, and there's always kind of a role to revisit at any point in your cancer journey. And sometimes even after surgery, after your primary cancer surgery, sometimes maybe you're not happy with the outcome, or maybe you have some pain, and that can be due to either the treatment, the radiation, the systemic treatment, or the surgery. And there's even a role at that point to revisit if surgery can make your quality of life better. So I
Hmm.
think there's, yeah.
So, can you tell us a little bit some of the terms that we often hear around surgery? One is obviously preventative, and that would be surgery that, could you explain what the role of surgery would be then?
Yeah. So when we think about preventative surgery, oftentimes it's people who have a family history of a specific type of cancer or have a genetic diagnosis of a cancer, like a genetic condition that can increase the risk of developing cancer, or have had a life experience that would increase the risk of having cancer. And so in those situations, sometimes we can remove the organ or the body part, or, for example, we often think about the ovaries and the breast is a very kind of common one. And so if we remove those, then you can decrease your risk of being diagnosed with cancer, and that can and remove that entire kind of experience from someone's life, which can be really meaningful.
Hmm.
I always say that the end goal of cancer, like where we want to go with cancer treatment and cancer care, should be like that cancer does not impact people's lives in any way, so that you can continue to do all the things you love as if you were never diagnosed.
Hmm.
And yeah,
That's a
we're
good
very
goal.
far from that, but that is
That's
the
a good
goal.
goal,
Yeah.
definitely. So, surgery that's used for diagnostic purposes, how is that played out? Like, how does that play out usually in the treatment?
Yeah, so I sometimes we see an abnormality, or a patient feels an abnormality, or someone, and we can't, despite our best efforts, we do all the investigations and we still don't exactly have a diagnosis. And so in those, or the flip side to that is sometimes we know there's a cancer, but we don't exactly know what type of cancer or what stage it is. And so in those situations, we can use surgery to give us more information to plan the best treatment afterwards. So if they would need some systemic treatment or radiation treatment, really we need to be able to remove what we see to be able to give a appropriate diagnosis and stage and know the best treatment after that.
And what about the term debulking? This is a term that I'm not that familiar with. What does that refer to?
Yeah, so we primarily use that term, and I don't do ovarian cancer or gynecological cancers, but I think that's commonly that where that word is used. And so I'll specify that I'm not a gyne oncologist, but we work quite closely with them, because there's also some abdominal cancers like appendix cancers and colon cancers that will kind of have a similar type of surgical treatment, than that treatment being debulking. And essentially what that means is that we're removing all the cancer that we can see, and then sometimes that's accompanied by other treatments to try to really make sure that there's no cancer cells left. And it's done to, increase the amount of time someone has without being cancer free. Um, and so, yeah.
Hmm.
It's a bit of a, like, in some ways it's a bit of a wild card, because you have to go into the surgery, and the surgeon often doesn't really know what they're going to get into. And so, going through that consent process, and again, it comes back to the trust and the relationship you build with your surgeon. You really, you're signing up for everything. You're just telling the surgeon, take out all the cancer that you see, and it can really be any organ.
Hmm. Yeah.
Um,
So, who makes the decision about about surgery and when and if to have surgery? Is that the surgeon's decision, or who plays a part in that?
Yeah, so we had prepared some pictures. So maybe I'll show one of the pictures now. Let me just get my because I think this is one thing that I try to tell my patients as much as possible because I think it's something that's really overwhelming. You guys can see that? Yeah.
Yeah.
So this is you, the person that has a new cancer diagnosis or is living with cancer. And I think sometimes they don't realize, a lot of people, even sometimes I don't realize, just how many people are truly involved in making sure the patient gets the best care possible for them. And these are all, I mean, this is, I guess, a breast cancer case because there's a breast surgeon, but these are all the different people that would be involved. So you have radiation oncology, radiologist, pathologist, even primary care providers, genetic counselors, physical therapists, social work, nutritionists, nursing team. So all these people really come together and contribute to deciding what the best care plan is for that patient. And it really depends on each patient. And that's really the future of cancer care is to truly try to, because what we're starting to see is our treatments are becoming so effective that oftentimes there's not just one best treatment, and it really has to be customized to that specific patient and what they want and what they value. And all these different people come, and we have our what we call case conference, multidisciplinary case conference. So usually we have those about once a week, and where most of these people, so the surgeons there, the medical oncologist, the radiation oncologist, the radiologist, and the pathologist, sometimes the genetic counselor too, and social work is often there as well. And we talk about a kind of each case, and we come up with a treatment plan that's specifically designed for each patient. So it's very rare that two patients will have the exact same treatment.
And I noticed too the plastic surgeon in here, and so that would be another role of surgery is the reconstruction.
Yeah, yeah, and I think the more like, the more the more our treatments get better and the longer people live, the more reconstruction and quality of life and cosmetic outcomes is becoming a really important part of that journey. Because again, it's always trying to make it such that the person's life and the people around them are the least impacted by the cancer journey.
Right. So in terms of when the decision has been made that now there's a surgery that's going to take place, what are some questions that a patient should be encouraged to ask of their surgeon?
Um, I so the questions that patients often, I think, there's often like a bit of a, and we see this a lot in the literature as well, is that as surgeons, we are very, and as healthcare professionals, we're very good at like quoting absolute numbers, like, oh, this risk of death, this risk of this side effect, this risk of that side effect. And I think like obviously those are really important aspects of questions that you should ask your surgeon, like what are the risks of complications? What are the alternatives to the treatment that you're recommending? And those are important questions. And those are really what we learn as how to do like an informed consent. So if you're going to have surgery medical legally, there's certain things that we have to say. But then what we're seeing more and more is what patients and people with cancer actually really want to know is how is this actually going to impact my day-to-day life? And things like, will I need help at home after? Will I be able to drive? Who's going to take care of my husband? Who's going to take care? Like sometimes oftentimes it's a pet, for example. I live alone and I have a pet and I can't be admitted to the hospital for 5 days because who's going to take care of my pet? And so I think trying to understand how you will function after surgery and for how long and how that will impact like your specific needs. Because I don't know if, unless prompted, sometimes it's hard to have that discussion. Things about like food and, when you go home after surgery, it can be really overwhelming. So making sure that you have the right food set up, so like your fridge stocked, people taking care of you, people checking in, all those are important things that aren't always brought up in the discussion because we're so focused on just getting the medical legal aspects out of the way.
Right. So that is a requirement for the surgeon to go through that with the patient in terms of what are the risks of this surgery.
Hmm.
Yeah.
And that's part of the informed consent process. But then I think what we're seeing is there's this whole other aspect of the discussion, which is kind of what we call shared decision making that needs to happen as well. And those are the more personal aspects of what surgery means to you in your life that I think we as a profession are trying to get better at doing.
And do you think that that's because when patients come to speak to the surgeon, they're maybe like intimidated by that process, or or they think that those things aren't relevant to the discussion, and so they don't bring them up?
Yeah, it's and I think this is more focused on like the new diagnosis, but certainly like when patients first come to the cancer center for the first time with a new diagnosis, they're just like it feels so overwhelming. And I think that much of the focus at that point is I just want to live, I want to survive, and I want to beat this. And those aspects of kind of quality of life seem secondary at that point because they just want to live. But what we
Mm,
see and what we hear is that, well, once you will survive, because our cancer treatments are very good now, so most people do survive. And then the decisions you make at the time of surgery and planning your treatments, those will have lifelong impacts. And so the classic one I think that's really hard for me is the young women who are diagnosed with breast cancer. They're very scared and they're starting a family. And sometimes they're concerned that like going through fertility preservation would delay treatment for their breast cancer. And they don't necessarily want to you know do that. They want to live. They want to treat their cancer. But then they do survive their cancer and then maybe sometimes fertility was maybe a bigger deal than they had initially thought it was.
right, right, yeah.
So
And it's the timing is often a really crucial thing here, where people feel that rush, that urgency to have their surgery right away, right? That's something that we hear is people are very
yeah.
anxious about it happening quickly. How important is that to the outcomes? Like, is there a certain urgency around doing cancer surgery quickly?
Yeah, so we have pretty good guidelines at like a national level that have really delineated what would be a safe wait time. And there's the government in Manitoba and every province does really good job keeping track that everyone is within those safe windows of time. Um, and so within those windows of time, I think it's safe, and that's what the evidence has shown, and that's what the government has approved. Because if we had people waiting unsafe times, then they would obviously give us more resources so that we could decrease that. So usually, if you're waiting, it's waiting within a period of time that has been defined to be safe. And what I always tell my patients is, even if it's safe, and I tell you it's safe, that doesn't make the waiting easier because the waiting is the hardest part. And we hear that over and over again that people just want to get on with their lives and they don't want to wait. And it's the unknown and the lack of answers, like what stage am I? What treatments will come after surgery? And I wish there was a way to speed that all up. Um, because that is, no matter how much you say it's safe, it doesn't take away how hard it is for patients to wait.
Yeah, definitely. The unknown. And there's often a fear that we hear about too, about people talking about the spread to lymph nodes. That's something that we often hear is like, if it has spread to lymph nodes, then the staging changes. Things like so. What exactly is that, and why is that critical?
Yeah, and maybe I'll share my screen again because I had a picture for that as well. Here you go. So we hear a lot about lymph nodes, and we hear about lymph nodes in almost all the cancers. This is just melanoma and this is breast because that's where we really see the lymph nodes and we specifically kind of pick them out. But so there's different ways to stage cancer. And I think this is a very kind of an abstract concept, but what we know is that if cancer cells are in the lymph nodes, that's a marker that the cancer is probably a little bit more aggressive. And so that usually will increase your stage. It doesn't mean that it's spread, it isn't any, like, it doesn't, people often think it's like cancer spreads like ants on a log marching along. But truly, it's just that we aren't very good at detecting cancer. And so we know we can detect it where it was initially diagnosed, which could be in the breast or the skin if it's melanoma, and we can detect it in the lymph nodes at a microscopic level. And so we use that information to decide if you would benefit from additional treatments to try to kill any other cells that might be floating. So it's really just a marker of how aggressive your cancer is, and it's not truly that the cancer itself has spread. I don't know if that makes sense. And it's a hard concept to understand, and it even took towards the end of my training, I really started to understand this. But we know that the lymph nodes is just a marker of stage. It's a marker of how likely the cancer is to come back somewhere else. And most likely those cells in those lymph nodes were probably there all along. And it wasn't necessarily because time went by. It's just that that specific cancer is a little bit more aggressive and now has the capacity to kind of be in the lymph nodes. I don't know if that makes sense. I think this is an important concept, Kathleen. So maybe you should try to ask me questions to clarify, because I don't think I'm making sense. But I think
I
people are very, very scared about it being in their lymph nodes and that it's spread to their lymph nodes. Whereas it's a marker. It's a marker of how likely it is to come back and not necessarily that it's spread there. Does that make sense?
I think that, I mean, if correct me if I'm wrong in terms of like understanding this, but that it's if there's cells in the lymph nodes, then the type of cancer that you're dealing with is the type of cancer that might have to be dealt with differently as
Yeah,
opposed to
exactly.
a cancer that wasn't detected in the lymph nodes.
Exactly.
And then you can stage it or grade it. I don't know, that's a difference between staging and grading that I'm not sure, um, but but that will help determine that, right?
Yeah, exactly. That's exactly right.
Yeah,
It's a marker. It's a marker of how we should be treating this cancer.
yeah,
Um, I
yeah,
mean,
and
we always like when the lymph nodes are negative, but when the lymph nodes are positive, we know that there's lots of good treatments that we can give that will reduce the risk of it coming back. So it's
okay.
not like that's sometimes the hardest conversation to have because they're recovering from surgery and it's 3 weeks later and you're
Hmm.
sharing the results about the lymph nodes and it's such a downer when the lymph nodes are involved. Patients get so down, but we
Yeah,
have a lot of really good treatments.
and I mean, and that's the language a lot of people use around that is that it has spread to my lymph nodes.
Mhm.
And we hear that a lot, right? That it has spread to my lymph nodes. So you're saying it's not necessarily that it spread, that perhaps it was a type of cancer that would be there anyways, or that it would make its way there.
Yeah.
Um,
And if it's in the lymph nodes, then that means usually it's a bit higher risk that it'll come back somewhere else as well.
yeah,
And so that's why usually those people will be recommended some additional treatments.
treatment.
And then
So,
that usually can decrease the risk back to someone that didn't have it in their lymph nodes, for example.
mhm. Yeah, and again, I invite our audience too, if you have questions or you want clarity around any of this, to please send us your questions in the Q&A. There was a question about that we received about um, is there an option to delay surgery? I mean, we talked about the urgency a lot of people feel and the anxiety about having it done quickly, but are there sometimes cases when people say, I'm just not ready for this right now. I'd like to delay it and put it off. Does that ever happen?
Yeah, so I think that's definitely where we want to go as as a profession is, basically the question you're asking is, can we predict your future? Like, can we
Mm,
predict if this cancer will grow, if this cancer will cause problems, and can we give you just the right amount of treatment? Because we know that some cancers we find, maybe they'll never become a problem, right? We know that. We know some cancers are very aggressive and they will become a problem, but we aren't very good at determining exactly how your cancer will behave. And so what we hope over time is we can and this is kind of getting into what we call precision oncology, where we can measure the specific kind of features of your cancer and predict this is how your cancer is going to behave, and these are the exact treatments that you're going to benefit from. And maybe there's some patients that don't need surgery or can wait. Hopefully one day we'll be like, okay, well, your cancer won't be a problem for 5 years, so let's just hang tight. Now we are nowhere near that. But
mhm,
that is the goal, is to be able to really predict what is your course and what is the treatment that you will benefit from. And
mhm.
we don't give you more treatment and we don't give you less treatment. We give you just the right amount of treatment.
With another question relating to this part of our discussion, what does poorly diffused mean?
Yeah, so poorly diffused is a feature of the cancer. And usually that means that it's maybe a slightly more aggressive cancer, and it can be found in it's usually kind of gastric cancers, how is what we usually use that terminology, gastric cancer, maybe some types of ovarian cancer, I'm not sure. But usually it's a bit more of an aggressive cancer. And again, that's just another feature we use that maybe they would benefit from some additional treatments to try to decrease the risk of it coming back somewhere else. So it's the features of the cell under the microscope that make it called poorly diffuse.
Okay. What can patients do in preparation for surgery or what are some of the things that you suggest as a surgeon?
Yeah, so I think there's lots of people can do, and I think the main ones are to, stay healthy, to eat healthy, to try to have a good mindset, inform themselves. I think things that like I really like to see is when patients are reading about the different types of exercises they can do and get prepared for their surgery. Sometimes they have like a little bag at home that they're preparing for when they have surgery. Some people like to plan for rehab. For example, they have private rehab that they like to go to, or they'll go to their like kid's house for a few weeks after surgery. And I think when we see that, it makes it just a little bit, the whole process is just a bit more positive for patients when they're very well prepared. So I think in today's day and age, a lot of people have done efforts to make sure that the information that's available online is usually high quality. And so there's a lot of support groups out there that people can access that are very high quality, and those usually have really good information. Talking to other patients, I think people have a lot of find a lot of comfort in that. People that have been through that, peer support seems to be really important. And I know like through CancerCare Manitoba does a really good job at connecting patients and peer support. So I think that's really important.
It's important, yeah. What are ARIS protocols? Can you explain what that is, and do all surgeons follow the same protocols?
Yeah, so it stands for Enhanced Recovery After Surgery. So maybe about 10 years ago, 10, 15 years ago, we saw that there was a lot of care that was being delivered around the time of surgery that was maybe based on just kind of what the surgeon had experienced and their preferences. So, for example, how long do you stay without eating? How long, like, when do you start walking? When do you start all these like little things? And we saw that there was so much variability in how long people stayed in hospital after surgery. So, what people said is, we're just going to standardize it to everyone starts eating post-operative day one. Everyone starts walking post-operative day one. And so they created all these protocols. And what we saw is that that actually gets patients out of hospital a lot quicker and a lot more, not just quicker, because it's not just about being quick, but also a lot safer, because we know staying in hospital if you don't need to be in hospital is also not safe. So it allows people to kind of get motivated to have surgery and then to be a part of their post-operative care to transition back to home. And so what that includes is a lot of preoperative education about what to expect after surgery, what the postoperative journey will look like, so that when the time comes, patients are engaged, they're walking after surgery, they're chewing gum. I know we talked about chewing gum. Um, and so it gives patients the education to be able to be a part of their care after surgery and try to kind of get out of hospital as safely and as soon as possible. Because the hospital is, no one likes to be in hospital.
So tell us, why is chewing gum important after? Is that for all surgeries, or is it just certain types of surgeries that you're asked to chew gum?
Yes, we do say it a lot for abdominal surgery, and the reason for that is because when we operate on the bowels and when we operate in the belly, the anesthetic can create such that the bowels don't really tend to move things forward as much anymore. So people get bloated and nauseous and feel like they have to throw up. And that's a common complication after surgery, and it can last a few days. So if you chew gum and you walk, it kind of, what we say is, gets the bowels moving, and kind of the return of function of your bowel will be quicker. And then you'll be back to a normal diet and home and off pain meds a bit sooner. So that's why we encourage things like walking and chewing gum, is to really have the return of bowel function.
Just on the point of diet, is there a certain diet that's recommended pre-surgery?
Yeah, so there's been some work looking at what we call carb loading. So I don't know if anyone here is into like marathons or anything like that. But they've looked at if people have a high carb meal the night before, then that can help with surgery. Now, don't quote me on that. But it's definitely been looked at, and some people do recommend kind of a high carb load before the day before surgery, because you have to think of surgery as sometimes that's what I tell my patients, like when you're going to go to sleep and we're going to be operating, we're going to be putting your body through a marathon. And that's how you really have to think of it. And so trying to maintain your nutrition pre-op is really, really important.
That's interesting. Um, in terms of the types of surgeries, can you explain to us what is a laparoscopy?
Yeah, so I have pictures, so I'll pull those up.
Just while you're doing that, Dr. Delisle. Just a question about lymph nodes that a patient had is, if you've had chemo before you've had your surgery, are they still able to detect if there was cancer in your lymph nodes?
Yeah, so that's often that's an area of active research right now. So usually they're able to see if the cancer was once there. So they'll say it was kind of complete treatment response. So they'll see scar tissue that the cancer was once there, but that the chemotherapy, for example, killed all the cancer. So we are still able to see, was the cancer ever there? Um, but the chemotherapy does make detecting lymph nodes a little bit harder. And I think that's something because our preference is to move a lot of these treatments to before surgery. So as we start to do that more and more, kind of how we think about staging and the things we look at under the microscope after surgery are starting to change as well. And
Hmm,
that's one of the big ones.
great. Okay, good question.
Yeah. Yeah. So here, let
Yeah,
me yeah, I had this picture too, but here, why don't we just do this picture? I took
sure.
this picture from a surgical team. This is just a surgical team that I think it was out in Alberta. And I took this picture because I think sometimes one thing that can be very, very overwhelming is that people don't realize. So this is like this is your cancer team. Like this is your outpatient cancer team. And when we say outpatient, we mean like you're coming into the hospital for an appointment. So these are all the people that are taking care of you when you're being seen in your appointments. But then when you're an inpatient, which means you're coming in for surgery, then these are usually all like you meet a huge different team, and it's almost as big as your outpatient team. And so I think in all these people, you'll meet them and they'll introduce you by their names, and it's so overwhelming, I think, sometimes. But they're really all taking care of you, and there's just sometimes we don't realize just how many people are truly involved in your care and making that your cancer care possible as well as your surgery. And I don't think it's just very overwhelming. That's often what I hear from patients is I've met so many people today and yeah, so you'll meet a lot of people throughout your cancer journey, and everyone is just so specialized in their one role, but we all work together. So then back to your question.
Yeah.
So this is what we call laparoscopic surgery. So I tried to pick it from different vantage points so people could appreciate how it's maybe different from an open surgery. So when we talk about open surgery, it was a cut down the midline, or it can be any cut. I'm just doing abdominal surgery, and then we actually go in with our hands into the abdomen. And so what we found with laparoscopic surgery is we use these kinds of instruments like this through ports, and then we blow up the belly with some air, what we call usually it's carbon dioxide because it gets absorbed a bit more easily. And so it creates like a dome, and then we can work in the belly through these tiny little incisions. And so what we've shown with the benefits of some laparoscopic surgery is that it reduces the incision, which can reduce the amount of pain medications as well as obviously the cosmetic outcomes. But overall, the quality of surgery is the same, whether it be whether it be laparoscopic or open surgery. It's truly just the incision as well as the recovery can be a little bit easier as well with laparoscopic surgery.
So there's no advantage to having open surgery if there's a choice. Like my thought too is like, oh, if it's an open surgery, somehow that they can see what's going on better and get their hands in there better. Is there
Mhm.
any advantage to having open surgery over laparoscopic if there's an option?
If there's an option, probably there's no benefit to one or the other. It's really just preference. Um, but what you bring up is a good point, and sometimes laparoscopic surgery won't be an option for specifically those reasons. There's specific things that the surgeon would need to feel with their hands in order to really be able to do the best cancer surgery possible. So usually we're pretty, we would never kind of compromise cosmetic outcomes or healing for cancer for the quality of a cancer surgery. So I think most surgeons are pretty judicious about their use of laparoscopic surgery only when it's safe and it makes sense for the cancer. And so usually those tend to be less like smaller cancers usually.
Is there a way to know how experienced your surgeon is with this type of surgery? Like, do they have to, or should they have had a certain amount of experience with it? It's how new is laparoscopic surgery? How long has it been around for?
So laparoscopic surgery has been around probably. I think the first laparoscopic surgery was in the 1980s. And then I think it started with gallbladder surgery was probably the main one that it started with, probably as early as the early 2000s. And now it's used, I think now, like most people who go through surgical training will have had the experience that they require to be proficient in those procedures. Some people will do a bit more training in like a more advanced, like for example, I do rectal cancer and I do it laparoscopically. So that was something that I had to be trained in addition to my residency training. So certainly, but I think that if your surgeon's offering it, then most likely then you know that like people wouldn't offer surgery that they're not kind of comfortable doing. So maybe like some people wouldn't necessarily offer some surgeries laparoscopic, whereas other surgeons might because they feel a bit more comfortable. So I think kind of that would probably be a good gauge of if it's safe, like whether or not the surgeon offers it. And certainly I think if it's not offered, asking why, and if it's something that's important to you, specifically like some people actually really do mind about the incisions and stuff. So if it's something that is really important to you, asking why it's not an option, if it's just because of provider experience or comfort level, I think it's reasonable to ask if maybe there's an alternative that someone might be able to do it.
Mhm. Are laparoscopic surgeries generally shorter in length?
No, they actually tend to be a bit longer. I mean, it varies, but for example, in rectal cancer, it tends to be a little bit longer because it's a bit more finicky, you could say. Like, you can't just get your hands in there and do the surgery. You have to operate with, it feels like little chopsticks.
I hope you're good at your chopsticks.
Yeah, honestly, sometimes it's just you want to get your hands in there and do the surgery, but then like you have patients that are going home like post-op day 2, which if they would have had an open surgery, it wouldn't have been that smooth.
Yeah,
So it's nice to
yeah.
see.
There's a question from one of our patients that's asked, why are there no surgeries done on prostate cancer anymore? I'm assuming there still are surgeries done, but are they not as common?
Yeah, so again, I'm not a urologist, but I think urology has done a really, really amazing job at exactly that, tailoring the treatment to the exact surgery. And so what we know is so again, I'm not a urologist, but what I understand about this phenomenon is that we've become very good at detecting prostate cancer because of PSA, like prostate cancer screening. And I think that I don't know if it's actually still recommended. I'm not sure, but I know there's been a push to maybe kind of de-escalate screening because we know a lot of people end up having abnormal cells in their prostate. And we know that many of those cells won't actually ever be life-threatening. So that again, I think it's a very foreign concept to people that, oh, wow, cancer isn't life-threatening. But that's because we're coming from like now we're so good at detecting cancer. It's not what it used to be, where before we would only detect it if it was very aggressive. Now we're detecting cancer cells like in the blood. And what we're starting to see is probably there's abnormal cells in everyone's body, and not all those will become life-threatening. And so we have to always make sure that the treatment that we're offering is not worse than the disease. And prostate cancer surgery specifically is quite morbid surgery because it obviously is in the pelvis where it can affect your urinary and sexual dysfunction, especially if it's not something that's going to benefit you. And if you have alternative treatments, like I think they do a lot of anti-hormone treatments with like anti-androgen treatment that are very effective. And so if you have a better treatment that will keep the cancer controlled and even cure you of the cancer without surgery, then that can be really good. And I think that would be something that all cancer types kind of should aspire to, because lots of old men have prostate cancer and are living very, very normal lives, which is awesome to see.
Yeah. Before we move on, because I wanted to ask you a bit about robotic surgery. There's some questions from some of our patients. So, is dysphagia, I can't say this, dysphagia as a common side effect of laparoscopic surgery of the esophagus? Dysphagia, how do you say that?
Yeah.
Dysphagia?
So that's like dysphagia. Yeah, so that's in
Dysphagia.
thoracic surgery or head and neck surgery, probably like esophageal
Yeah.
cancer surgery. And so I think that the risk of dysphagia after again, not a thoracic surgeon, but I would say that the risks of dysphagia probably aren't dependent on laparoscopic versus open surgery, but more so the treatments of your cancer and how, like if you had some radiation, if you had systemic treatment, and then where your cancer was located and how aggressive it is. because that connection, when they remove the cancer around the esophagus and then they have to redo that connection, it can sometimes lead to issues with swallowing, which is maybe what that individual was asking. And so, yeah, esophageal cancer is one that also we're trying to see how we can make the treatments better, because the dysphagia and other issues with eating and swallowing can really impact people's quality of life. And it's common with that cancer type.
Another question from someone had a laser comb biopsy and they don't have much cervix left. Are they able to get laparoscopic surgery? Is that enough information for you? I don't know.
I don't know if I know the answer to that.
Yeah,
That's probably a bit too niche in gynecology for me.
yeah, yeah, for sure.
Um, but
But perhaps,
I think definitely something that I would empower you to speak with your gynae oncologist about that, if that's what's
mhm,
something that's important to you.
right. And that person can also contact us and we can put them in touch with the gynae cancer nurse educator as well. She may be able to have some information
Yeah,
about that.
yeah.
Um, there's another question that says for preparation of upcoming surgery, how do you analyze the diagnostic CT or MRI images for zeroing in on the cancerous tissue? Are there specific diagnostic tools that are more consistent for the surgeon to minimize any surprises?
Yeah, that's a really good question, and something that a lot of people are working on. So there's some companies, like one of them in particular is called Stryker, that's trying to develop tools to help us visualize cancer better on imaging. I think we have very experienced radiologists, and most all cancer surgeons will review all the imaging again at those kind of multidisciplinary case conferences. They'll review them with the radiologist and they'll have a roadmap in their minds. Sometimes they use MRI and PET scan as well. And so those are all tools that you can use to try to get the best idea of what the cancer is before surgery. Um, and really, I think it's just relying on some very, very good radiologists, as well as kind of yeah, I think it's really the radiologists are excellent, and our imaging techniques are getting better and better. Like if you look at CTs from 5 years ago compared to CTs now, it's like sometimes I don't even, yeah, the technology is getting much better, and it's really exciting that like what they're trying to do is develop different dyes that will stain different cancers, so we can even kind of have a better visualization of that ahead of time. But definitely that technology is not there yet, but I think it's in the near future. Hopefully we'll have something like that.
So, speaking of technology, it's a good segue to ask you about robotics and surgery. How familiar are you with what's happening now in terms of developing like almost like remote surgery using robotics?
Yeah, so we had a picture of robotic surgery, so and how it kind of differs. See, this is actually the fluorescence. So this is the fluorescent. This is a picture of a surgery, and you can see that it's lighted up green. And so we have that technology right now, and it's not specific to cancer, but they're trying to develop different kind of agents that will attach to different cancer cells. So that's actually a good example. So this is laparoscopic surgery, so like through the chopsticks a little bit, that give you kind of 180-degree movement. And then robotic surgery, which I guess you can't really see, but they give you 360-degree movement. And so there's a lot of benefits and then the surgeon just gets to sit, which is also really nice. Whereas here we're standing and it's like very painful on the shoulders. And here you get to sit and it's very comfortable. Not that that's important, but it does make a big difference after a career. And so robotic surgery is really good because it gives you the 360-degree movement with your instruments in the patient compared to laparoscopic surgery. The issue is that the studies have not shown a benefit. Like truly the benefit to robotic surgery is really in the ergonomics, because it's much more natural for a surgeon for them to be able to have 360-degree movement in the patient. So it's truly ergonomics. And so for most surgeries, that would be the main benefit. But then what we're seeing with these highly technical surgeries, like a Whipple, or sometimes even with like a Whipple is a type of pancreas cancer surgery. And so even with prostate cancer as well, because it's so deep in the pelvis and that it's so hard to access that area of the body laparoscopic. So for those procedures, there's probably a benefit to robotic surgery and being able to do it through the smaller incisions, because in laparoscopic surgery, it just becomes impossible unless you really have that 360-degree mobility. The issue is that these are very, very expensive. Obviously, you can see this is super expensive equipment. And so it always comes at an opportunity cost. And so you have to think about like, if there's not a major benefit to patients, that's how our healthcare system thinks about it. If there's not a proven benefit to patients, then is the money best spent in this way? Because it comes at a cost for other like cancer drugs and things like that can actually have a proven benefit to patients. So I think robotic surgery is still trying to find its home in Canada. Um, because of our publicly funded healthcare system, we prioritize things that really have had a proven benefit to patients. And so for this, there's some that it's a minority of procedures that robotic surgery has been shown to be beneficial compared to laparoscopic surgery. And it's never it's never with regards to the quality of cancer surgery. It's really truly just being able to stay through the tiny incisions, which in the grand scheme of things, the tiny incisions are I think studies have shown the length of the incision, it matters to about 4% of patients. So in the grand scheme of things, kind of the length of the incision and being able to do it through laparoscopic and robotic surgery versus being kind of having access to treatments and drugs that will cure you of your cancer. Yeah, you just have to consider all those things.
Makes sense. Yeah. Um, in terms of, obviously there's risks, as you said, that are disclosed like prior to surgery. And this is relating to that. Somebody said if they had surgery on the bowels, would there be any fluid leaking into the abdominal cavity afterwards? And is there any way to minimize the risk of that? So they're referring to interstitial, is that it? Lymph fluid?
Uh, Interstitial lymph, like a lymph leak. So I think there's a few things. Maybe I'll try to tackle this from the different ways. So definitely when we ever were doing bowel surgery or any type of surgery where you're removing something and then reconnecting it, we always worry about that connection. And the reason, so we make that connection with these like little staplers, with these little metal staplers that really are just a stapler. It's like a medical grade stapler.
Mhm.
And so that's how we make our connections. And I think that's one of the complications that we really fear the most because it can make patients really sick. And so usually that's why we try to, we do when you're in hospital after surgery, we monitor your vital signs, we monitor your blood work, and any kind of early signs of infection. Really, we take that quite seriously and do CT scans, imaging to try to see if there's a complication. And so really what we look for kind of early detection and early rescue of any complications that might happen. And then there's different techniques we can use in the operating room to make sure that connection and those things can be minimized. And so we try our best to do that.
We're talking about surgery and in general, again, in terms of like the techniques and do some people stay awake throughout their surgery, and how does general anesthesia work in surgery?
Yeah, so there's different types of anesthetic. So like you mentioned, there's the general anesthetic, and that's through the breathing tube where you're not breathing on your own anymore. And then, so that's the one extreme of the anesthetic. And then on the other side, you can just do it usually with like some freezing, like you would go to the dentist and get freezing. And then in the middle of that, there's some things that the anesthesiologist can do, which is what we call some nerve blocks. So the anesthesiologists have become very good at finding the nerves that are going to supply the area where you're doing surgery. And those nerves are going to give that part of the body the sensation of pain. And they can actually infiltrate the nerves with a freezing agent. So you lose sensation to that specific part of your body. So I've never had an epidural, but apparently that's what an epidural feels like. So we can do that, but we can do it in many different parts of the body now. And so that's a really attractive option because it minimizes some of the side effects from a general anesthetic that we often see. So like nausea and vomiting is very common. And also I think that some confusion after surgery, after general anesthetic can also happen. So if there's an option for what we call a regional anesthetic, or regional meaning one part of the body and not a general meaning your whole body, then that's an attractive option.
Okay. And if people often well, maybe not often, but I've heard people express fears about, waking up during anesthesia, like general anesthesia. how likely is that risk that somebody could wake up when their surgery is not finished?
Yeah. So we actually, when I was a resident, we had someone come and talk to us that had that, and it's very, very scary when it happens. It's very, very, very rare. But certainly there's reports of that happening, and so there's different. We actually now they use like monitors on your brain so that they can monitor if you're truly kind of asleep with those monitors to help decrease that. So there's things that have come into place to reduce that risk because it is a very much feared complication, but it's very, very rare. And I'm not 100% sure what causes it. I think it's like kind of how some people react to the anesthetic and stuff like that. But since that's why they use those brain monitors now to try to make sure that the patient is truly in like a sleeping state.
Okay. Um, in terms of you talked about local anesthesia and to control pain, but post-surgery, what is usually recommended for, I mean, that's a general question again, but to control pain after surgery?
Yeah, so there's different. So there's again, I'm sure everyone has heard about kind of the opioid epidemic. I don't know if anyone's heard of that, but it's in a lot of different news channels, um, and so there's been a lot of awareness that's been brought to like kind of prescribing habits after surgery, and to make sure that you're prescribing just the right amount of pain medication, not more, not less, and to really be kind of mindful of some of the negative consequences of some of the opioid medications we use, and particularly they're addictive. Some of them can be addicting. And so the amount of pain medications that a surgeon will prescribe will depend on the surgery. And there's been some guidelines that have now been published to make sure it's just the right amount and to really reduce the risk of any negative consequences related to those pain medications. And I think we're also becoming a lot better at making sure that people are doing like kind of what we call multimodal pain control. So things like Tylenol, Advil, ice, warm packs, mindfulness exercises, those are all things that can be built into a pain kind of control regimen. And I think also the last thing I would say is sometimes there's a tendency to just try not to move after surgery. Like, for example, if you're having surgery on your armpit, then people kind of don't move their arm. And then that can really lead to problems. Again, you'll have specific instructions after every surgery, but just if you're allowed to move, to make sure you are moving and not staying immobile, because that can sometimes lead to bigger problems as well with regards to recovering from surgery.
So that's one of the ARIS protocols as well, is it not? Like just to for people to get moving following
Yeah,
surgery?
yeah. E-mobility. I mean, I think orthopedic surgery is a bit of a different kettle of fish because sometimes in orthopedic surgery on the bones, you actually can't move because the bone is healing. So ignore that. But most of the time, and obviously follow your instructions of your surgeon. But I think if you're instructed that you can move, moving is always a really good thing.
Somebody had a question about any tips for helping the burning feeling on or around the stoma after getting an ileostomy.
Yeah, so that's definitely something that they should meet with. They should have a stoma nurse meet with them because there's lots of tips and tricks. Usually it's because the stoma appliance may not fit I don't know if the stoma appliance is fitting well, but that's usually the first place because it's the burning sensation. I mean, it might be that they're allergic to their actual stoma appliance, but definitely you should be meeting with a stoma nurse because that definitely does not need to happen. And there's so many different things that can be tried.
Okay,
Uh,
great. Yeah.
yeah.
Another question about surgery. Can surgery be used to remove cancer from your bones?
Um, Yeah, so I think like there's different, it depends again, every cancer is a bit different, but certainly if it depends if it's spread to your bone or if it started in the bone. And so the reason to use surgery for the bones has to be kind of decide, each case is a bit different, but certainly if there it makes sense to remove a part of that bone for that, I think there's a lot that I think there's a few there's one orthopedic oncologist in Manitoba, and that's kind of his what he does, but the reason for removing it when it's in the bone has to be kind of understood, because usually kind of cancers that spread to the bone are more common than cancers that start in the bone. And we start talking about removing cancers that have spread, the reasons for doing that become less and less because radiation is often really a good treatment for that as well.
Just talking again about post surgery, and we talked about the importance of moving. What is deconditioning? That's a term that we've often heard too.
Yeah, so what we see often is patients come into the hospital and then they because of there's so much going on. And they're not eating what they're usually eating. They're not moving as much as they normally move, mostly because of pain and related to surgery. And sometimes they can't actually move, like they can't actually get out of bed because they're attached to things. And so we know that the longer you stay in bed, like I think some people quote like 1 day in bed is like, takes 4 days to recover from. And so we know the less you move, the longer it'll take you to kind of regain your strength back because your muscles really start to deteriorate the longer you stay immobile.
Okay. So we talked a little bit about medication and dealing with pain. The question of of symptoms of cancer and having pain associated with cancer, how does a patient that's had surgery differentiate between this is post-surgery pain or something's really wrong? Um,
Yeah.
and is this my cancer? Like not the recovery from my surgery that I'm feeling.
Yeah, and I think that's something that some people call it scanxiety. There's a lot of different words, but I think the fear of cancer and the fear of cancer recurrence is really, really something that's really hard for people. And at the back, I think it's often at the back of their minds anytime they feel the slightest twinge, oh, is this my cancer that's back? And so usually, I mean, each cancer is different, obviously, but I think immediately after surgery, it's so unusual that it would be related to a cancer recurrence. I mean, nothing's impossible, but it would be very unusual for that to happen if the goal of the surgery was to remove the cancer. And so then when we start talking about like people often when they're in hospital and they're being monitored, their blood work's being taken, their vital signs are being taken. At first it's like so annoying they just want to rest. But then I find they start to notice is they actually like the reassurance of knowing that everything's okay. And then when they transition home and they don't have those checks, it can be like they're like being released into the wild and it feels a little bit it feels very hard. And so things that they can, most of the time they're given like a nurse that they can call as well, Monday to Friday. And so definitely lean on that resource because they'll be able to coach you through symptoms that you might be having. And then the other thing is that usually you'll have ups and downs, but it's usually a trend. So if it's been a day that things are getting worse or 2 days that things are getting worse, usually that's probably something's wrong. Whereas usually you'll have a morning that's bad, but then it'll get better by the afternoon. But usually if it's been going on for a day or 2 days, maybe something's wrong and you probably need to get to the hospital or
Hmm.
make sure you call your nurse or your family doctor as well.
Right. Or the Cancer Care helpline
Hmm.
would be helpful as well. Um, a question from one of our audiences, what does a PET scan show?
Yeah, so PET scan uses a specific dye that is very active, like that it's a dye that cells that are very active will pick up. So it's meant to show very fast dividing cells, which is what cancer is. So when you look at a PET scan, things that are what we call like light up on PET scan, that's what we'll use. They'll say light up on PET scan. That usually means that specific thing is growing or dividing very quickly. And so that doesn't necessarily mean it's cancer. For example, the brain lights up on PET scan because it's so active. But then, so we know where normal parts of the body light up, and then there's parts that shouldn't light up. And so when we see parts that shouldn't light up actually lighting up, that usually means maybe there's cells that are dividing more quickly there. And it could mean that it's an infection, or sometimes it could mean that it's a cancer, part of your cancer.
Hmm. When is a PET scan usually requested as part of the treatment plan?
Yeah, so different cancers again have different indications. So like in esophageal cancer and in lung cancer, it's used very commonly, whereas in colorectal cancer and breast cancer, it's not used that commonly. In melanoma, it's used very commonly as well. So it really just depends on the type of cancer, and when it's used.
Mhm. Just a question again about post-op practices. Like, is there a way to reduce scarring? And you mentioned that, incision length isn't usually a really important factor for people that are undergoing cancer surgery, but is there something that's recommended that can help people heal their incisions?
Yeah, so there's things like vitamin E and bio oil, and I think there's also these like collagen strips that you can put on to your incisions as well. Those are all things that you can do. Or I think they're like hydrocolloid collagen strips that people can get. I think the other really important thing is if you develop an infection in your surgical site, that really increases the scarring. So to try to keep it clean and healthy, because if you get an infection, usually the scar will be a lot worse.
Mhm. Speaking of infections, what is that infection that sometimes people can get in the hospital? Like that's
Hmm.
also something we often hear people talk about, like they went to the hospital for this and then they got this really horrible infection when they were in the hospital. What is that called and what is it
So
exactly?
there's a few different ones. The two common ones is MRSA. So that's a kind of a bacteria that can colonize people, and that we tried. That's the first one is that you can become colonized with a bacteria that can be resistant to some antibiotics, and so usually we try to keep that because we don't want people to have that resistant strain. Not because it causes an infection, it's just that if we have so much resistance in our population to that specific antibiotic, it's not very good because it's an important antibiotic. So we try to control the resistance patterns. And then the other one is called C. diff, is another common one we talk about. So that's the kind of it just gives you very bad diarrhea. And it's usually that it being in hospital as well as being on antibiotics that'll give you C. diff. And the reason for that is because the antibiotics that we give you in hospital will change the flora of your gut, and then it'll make you more likely to develop C. diff. That's what
So
it's called.
so people don't get this infection from the surgery, but they get it from being in hospital,
Hmm.
maybe for surgery, and then having is it like their immune system or a
Yeah,
reaction thing?
exactly. Yeah, exactly.
Okay. Okay. I
Yeah.
thought it was actually something they were catching.
Well, it's kind of a combination, but like, like as a normal, like I can be around people with C. diff, but my immune system isn't low and I'm not on antibiotics, so I haven't had surgery, so I've never caught C. diff. So it's a kind of a combination of being immunocompromised in the hospital on antibiotics and then someone else in your area usually having it that will give you.
Hmm.
So those are
Okay.
the risk factors. Yeah.
Is there anything else that people can do pre-surgery to improve their immune system so that they're more resilient to these risks?
Yeah. Um,
You
again, I
talked
think
about
yeah.
exercise and diet and
Yeah, I think
mm,
exercise, diet. I know, for example, if people maybe have a little bit of extra weight, like obesity can be really hard for surgery. It can really increase your risk of complications. And so sometimes some surgeons will do like an OptiFast diet, it's called. So for like the 6 to 8 weeks before surgery, you just have these like boosts, and then that will help decrease at least some of the fat stores that will really decrease your risks of complications. So that's another one to consider talking to your surgeon about. But usually we only talk about that if their weight is really kind of over a certain point. But for those patients, it can really decrease their risks, particularly of like respiratory complications as well.
mm.
It can be really beneficial. Um,
And what about smoking? I mean,
yeah,
is
that's the
that a
other
risk
one.
factor? Yeah.
Yeah. So there's a lot of resources through CancerCare Manitoba to help. Um, And so smoking cessation is good. I think that usually if you're going to try to stop smoking, we try to do it like at least like kind of 8 to 12 weeks before surgery if possible. So if you think you're going to be like because from the point that you have a diagnosis of cancer to the time of your surgery, it often is around 8 to 12 weeks. So I would say like if you can stop smoking, it's so hard for people to do, particularly when they have a new diagnosis of cancer. It's like the last thing they want to be thinking of. But if you can, it's really, really helpful.
Okay. What type of test should be done for gastrointestinal cancer? Is there any tests that are given to determine that?
Yeah, so we can do different kind of endoscopy tests. So we can do camera tests from through the mouth, through the bottom end, CT scans. There's some blood tests that can be done as well. There's sometimes we just look in with a camera into the belly just to see the different types of cancer if we're not sure. So those would be some of the things we use.
Okay. Question about chemotherapy following surgery. Is there a protocol in terms of how long you have to wait following surgery to begin chemotherapy, or is chemotherapy not always necessary after surgery?
Yeah, so it's not always necessary after surgery. Again, it depends, and maybe I'll go to this slide here. This is a really good resource, mypathologyreport.ca. It's designed for patients, so it's to help you understand your pathology report. So about 3 to 4 weeks after surgery, we go through the pathology report, and that is what will determine, that's a large part of what determines if additional treatment is needed. And so not all cancers will need treatment before or after surgery. It really depends on the type of cancer and what we know about it.
So that's done following any surgery in an oncology. There's always a pathology report that's
Yeah.
completed, and then
Yeah. And that's
okay.
one thing that I would want to encourage people that are on this webinar is to ask for copies of your reports if you're comfortable. I mean, if that's not something that's important to you, that's fine. But I know there's more and more people that are trying to get those reports into patients' hands and let them own the data, and to be in control of their care. And that's where resources like my pathology report becomes really important, because it's like you have all these words in front of you and you don't know what they mean. But it's really important that you have this data, because it is your data and you are in charge of, like, it's your data, your care. And I think it's important that patients really kind of are empowered to, if they want. I mean, some patients find it overwhelming, and that's totally fine, but don't ever be afraid to ask for copies of your reports and stuff like that.
Okay, good. Just another question. How does alcohol affect surgery?
Yeah, I don't know if we know that specifically, other than we generally try not to. You can't drink in the hospital, but
Mm.
but
Even though you
before.
might want to.
Yeah. After, like, if you're on pain meds, it can kind of interfere. Um, and so just being mindful of the medications you're on, and obviously like the healthy drinking guidelines. I think it's like they decreased it, didn't they? I don't really drink, so I don't know, but didn't they
Hmm.
decrease it to like 1 drink a week or something crazy? I remember an
Hmm.
uproar like that. Everyone couldn't believe how little. So I guess, yeah, making sure that you're following like healthy drinking guidelines and stuff like that.
Yeah. There was another question, the last question, I guess, about what foods to eat that might improve your chances of cancer reoccurrence or help cure you from cancer. That might be a better question to ask our dietitians, perhaps. Like that's a broad question.
Yeah, that is but I would say that like like one thing I have a few different perspectives on this. So again, not a dietitian, so yes, ask the dietitian, but I think different patients will react differently to different diets, and there's so much out there that I think just finding one that works for you. And I have had patients that have, like, the nightshades, that like they avoid nightshade foods or something, and that works for them and they're living their best life. Like, and I would 100% encourage them, if there's something that works for you. The thing that I think is makes me a little bit sad is sometimes there's like these diets that are very expensive to maintain, and I don't know what the benefit is. So just being mindful that there is a lot out there that's written, and to maybe, at the end of the day, everything is a little bit of a business. So just to do your homework and to speak to people like your dietitian at CancerCare Manitoba and stuff like that, to make sure that like the what you're reading and following is uh is good quality.
Yeah, that's great.
And then there's
Wait,
other things, like the people will often go on like sugar-free diets and then lose weight around surgery. I think like losing weight around cancer surgery makes everyone a little bit nervous. So maintaining a healthy weight and not going on to like a strict diet can sometimes, yeah.
when I read about that carbohydrate, what is carb loading? Is that what it's
Hmm.
called? Carbohydrate
Yeah.
loading. Yeah, I thought that was interesting. And like how you said about sort of the person's going to be like going through a marathon when they go through surgery and needing that
Hmm.
uptake of carbs in advance. I've never heard that before. I thought that was interesting. We've had some excellent questions from our audience today, and just throwing them at you really quickly. And you've done a wonderful job, Dr. Delisle, answering all these questions. But we do have a few minutes more. If anybody has any last questions they would like to ask, now's your opportunity. I'm just wondering if there was anything that I had still wanted to ask you that I hadn't got around to, but this has been really informative, and I know that we've spoken about surgery in fairly general ways today because we can't be that specific about certain types of cancers. But there's just some really interesting research too around the and as we said before, like surgery is the oldest method of cancer treatment, and it's evolving and changing, and how it's being used in cancer treatment is changing all the time. So I just really appreciate the work that you're doing
Yeah.
and what you're doing for patients. It's so valuable and it's really admirable. And Thank you
Well,
so much for being here today.
well, thank you for, I don't know if any of the, I have a few partners that I work with in some of my research, and they really love all the work you do. And so thank you for all your support. And
One last question that someone just gave us. Do you have, does radiation benefit someone who's already had surgery? Um, there was no cancer cells that were seen, but radiation was still recommended.
yeah, I think again, it's always it depends on the specific cancer type and stuff like that. But one thing is, like, as our systemic treatments and cancer treatments become better, we just need, sometimes it's just getting the evidence to support kind of what we call de-escalation of treatments. And so even if the recommendation is right, sometimes it just doesn't make sense. Like, there's no cancer cells, why do I need radiation? But oftentimes it depends that the studies to de-escalate those treatments have not been done yet or are actively being done. So the recommendation has to remain radiation until we have the evidence. Sometimes we're going faster than we can keep up with the studies.
Mhm.
But I think the people are asking like patients are asking always, their patients are getting really good at asking the right questions. Like, do I really need this treatment? Because treatments have consequences too.
True. Yeah. Thank you. We just had a message from one of our audience that it was an excellent webinar, and I agree. Thank you, Dr.
Well,
Delisle.
thank you for having me.
Yeah, it's been a pleasure, and thank you all again for your excellent questions. And take care for now.
Bye.
Okay. Bye
Thanks.
now. Bye.
Bye.